Friday the 13th. Many people look at Friday the 13th and like, in fact, there's somebody who has said, I'm not leaving the house today. Me, I have experienced things on Friday the 13th before. I know I have experienced when this date. I am not leaving the house. But our guest has left the house. And
has come here.
And he has come here and is in the studio. Dr. Kireki Omanwa is the president of the Kenya Obstetrical Gynaecological Society. He's our guest for the Health Friday conversation. Daktari, good to see you again.
Thank you. Thank you very much. And I'm glad to be here.
Karibu sana.
Asante sana.
Karibu sana. You know, your other president, your colleague, the other president, is celebrating 2 years in office today. How many years have you been in office, Bonner President?
3 years, going to 4 years.
Yeah.
Going to 4 years, yeah. Slightly longer than the other president.
Is there a term limit?
Yes, there is a term limit, 3 years, and then it can be renewable once. So 3 plus 3.
Oh, so you're serving a second term?
We are having elections next year. Yes.
You and the other guy can have a conversation.
Yeah, we can.
Okay.
Since you're both presidents.
Karibu sana.
Asante sana.
You're here today for our Health Friday conversation, which is about understanding postpartum hemorrhage and why it's a number one killer in women.
Correct.
Now, when you hear number one killer in women, you're like, okay, wait a minute. This is a big one. We want to hear about it. So first, let us hear the day's proverb from CT.
Okay.
Yeah.
Our proverbs for the whole of this week have been from the Federal Republic of Somalia.
Our neighbors.
Here. Horn of Africa.
Hapa tu.
Hapa tu Simbali. Yes. Hapa. Kismayu. Mefika. A beggar and a ruler know people best.
A beggar and a ruler know people best.
A beggar and a ruler know people best.
Yes.
That's an interesting one. Quite challenging, I would say.
I thought so too.
I would imagine a beggar, let's say somebody on Koinange Street or Moi Avenue, somebody who's been there for some time, and usually they have their own spots there, and they are sort of a repository of knowledge because of the people they see, the actions they see, what is happening, and sometimes even if there is danger, they are a lot easier. They say, "Usiende hapo, kuna shida." So I would think in that respect, when it comes to the leader, if you were to say that. You have been in a position for some time. You know the going-ons of an institution, the people who are working there. You know the strengths and the weaknesses of the people there. So you have all this knowledge which you can apply either positively or also negatively. That's the way I would interpret today's proverb.
What do you think it's telling us?
Sorry?
What do you think the proverb is telling us?
What I think it's telling us is that knowledge is power. That once you have knowledge, you can be able to apply it, and you can be able to apply it positively or also negatively, unfortunately. And the beggar who is at the bottom of the pyramid and the leader who is at the top of the pyramid all have different types of information, and this information, this knowledge can actually be used positively or negatively.
Oh, fantastic. That's a good one. Knowledge is power.
Knowledge is power.
Now, let us also get more power now. Postpartum hemorrhage.
Yes.
What is that?
Thank you. That is a problem, a very big problem in this country. But maybe before even diving directly into it, I would take a step back. I would quote from the Bible. The writer of Psalms, David, I think it's Psalms 134 verse 19, says that I will praise you, O Lord, because I'm fearfully and wonderfully made. I don't know what he had looked at or what he had thought about to come to such a conclusion, but I'm sure when he looked at what had been going on in his life, he came to that conclusion. When we talk about PPH, that is postpartum hemorrhage, first of all, we need to understand a little bit about how the body of a woman behaves. If we look at the uterus is a tiny organ. Basically, when it's not carrying a baby, it's not gravid, it's about 120 grams only. Now, when a woman gets pregnant, this small organ grows to accommodate a baby, who on average can be anywhere between 3 kilos, 3.5 kilos. It accommodates the fluid that surrounds the baby. It accommodates the placenta, and so on. Now it stretches from that 120 grams, and it reaches, several kilos. If you are to weigh all these, elements together. Normally, when a woman delivers, whether through cesarean section or whether vaginal delivery, once the baby has been delivered, there is what we call the placenta. And the placenta is what connects the woman and the baby through the cord, what we call the umbilical cord. That is why we have an umbilicus, because that is where the cord actually connected us to our mothers. Now, when this placenta comes out after delivery, there is a small amount of bleeding which occurs, which is absolutely physiological. It can be anywhere between 100, 150, 200 milliliters. That is normal delivery. In a cesarean section, it could be slightly more. 300, 400, maybe even up to 500 milliliters. That is acceptable. When we talk about postpartum hemorrhage, it is a situation whereby the baby has been born, the placenta sometimes has come out or has not come out completely, and there is bleeding. And this bleeding is over and above what we expect it to be. So in the vaginal delivery, 200 milliliters, you find this woman has bled 600 milliliters, sometimes even 1,000. She had lost about a liter of blood.
Wow.
In a cesarean section, instead of the 500 mils, she has bled also. She has lost a liter, 1.5 liters, or even sometimes more. And that is a big problem in this country.
Where does the blood come from?
Thank you. Remember the placenta.
Yeah.
And there is the baby.
Yep.
In order for this baby to get nutrition and to get oxygen, it has to pass through the placenta, from the mother's circulation, the placenta, the cord, to the baby.
Yeah.
And also some of the waste products also come that way in the reverse direction. Now, remember that the uterus has vessels. So these vessels is where the blood comes from. So they're intertwined and they pass through and they give and they come where the placenta is attached. That is where those vessels are. Now, sometimes when a woman delivers, you find that after the placenta has come out, those vessels, normally the uterus is supposed to contract. And once it contracts, it seals those vessels which were open. But sometimes it doesn't happen that way because of different reasons. The reasons can be, for example, if the womb is overstretched, the uterus is overstretched. And what can cause that overstretching? Number one, you may have, for example, an excessive amount of amniotic fluid, what we call polyhydramnios, for different reasons. You may have the baby has some problems either with the digestive system or even with the urinary tract system. So you find that circulation is sort of hampered and there's an excessive fluid accumulation in the uterus. You may find that the baby
and this is during
big.
pregnancy.
During pregnancy. You may find that the baby is big. What do we mean by big? The other time I was on call in KNH and we had a patient who had 3 or 4 babies, and all of them were 4.5 kilos, 4.7 kilos, and even a 6 kilo baby she had delivered in the past. So that uterus is overstretched such that even the normal mechanism of it contracting is sort of shortchanged and it doesn't happen. So what happens is when it's stretched like that, remember those vessels that I talked about? They are not sealed, so they continue bleeding into what we call the cavity where the baby was. You may have a woman may have fibroids, for example, and these fibroids.
What are fibroids?
What are fibroids? Thank you. Now, a fibroid is basically a growth on the womb, and unfortunately 30 to almost 60% of women of African origin will have fibroids somewhere in their reproductive age, and these fibroids can be very tiny or they can also be very big. It can be one fibroid, or they can be several of them. So, for example, my friend did surgery and wrote an article, and he said his was 140, meaning he had removed 140 fibroids from a patient and managed to save the womb. So when these fibroids are there, that contracting mechanism also is hampered. And even the process of having natural delivery, because natural delivery is basically driven by contractions on the uterus. So if there is something that is impeding these contractions from happening, it will lead to either the woman may not deliver, or after delivery the contractions will not happen and the vessels will not be sealed. This will lead to postpartum hemorrhage.
How common is it? And two-pronged question.
Yes.
And in what age group is it common? And what are the other variables that contribute to it?
Thank you. Now, maybe I'll start with, let me start with the first question. How common it is? Very, very common, unfortunately. We look at what is called maternal mortality rates. What does this mean? It means that when we look at the number of women who die when they are pregnant, during delivery, or 6 weeks post-delivery, and our numbers are not good, unfortunately. The government official figures say that our maternal mortality rates are about 355 women out of every 100,000 women who die, who deliver. So if we were to say that, just for the sake of discussion, that we have 1 million deliveries in a year, it means that 3,550 women will die. It's huge.
Yes.
Now, that is what the government is telling us. But when you look at...
Because we know by statistics, we actually have around that, 1 million deliveries a year.
Actually, it's about 1.6 million.
Okay.
Now, Uganda has 2 million deliveries. Now, if... when you look at other international organizations, they say that our maternal mortality rates are a lot higher than the 355. What UNICEF is telling us, what UNFPA is telling us, WHO is actually approximating that our maternal mortality rates are about 550 out of every 100,000 women.
Where are they getting their figures from?
I think they have their way of collecting data, because these are NGOs and they have their people in different areas, even in very far-flung areas where they collect this data. We have a sort of a challenge with data collection on our side, on the government side, because you find that some of these deaths occur either in private facilities, faith-based organizations, or even private facilities, and they are not reported. So we think that there is a gross underreporting of our maternal mortality rates. And this puts Kenya not in a very good light, because when you look at every time we go for a conference or, we meet to discuss what is happening in the world in terms of maternal health, of course, they always say sub-Saharan Africa. Everything sub-Saharan Africa. And when you look at maternal mortality rates in sub-Saharan Africa, number one is Southern Sudan, which has about 1,000, is it 1,200 or 1,600 out of every 100,000. Chad has, I think, 1,067. Nigeria has about 1,043. What do you call Central African Republic, about 800 and something. So we are there. But when you look at other countries, of course, there are countries where maternal mortality rates are actually either very low or not there. It's countries like Luxembourg, Slovenia, and so on. Poland has a maternal mortality rate of 2. Belarus has a maternal mortality of 1. The US is about 21. When it increased to around 23, there was a huge outcry, and their society actually started to find out what is exactly happening. And when they did their research, they found out that actually their numbers were increasing in those states whereby Wisconsin, Wyoming, where their access to rural healthcare was also very, very poor. Yes, the UK, for example, has about 10, 15, and so on. So in European countries, the maternal mortality rate is very, very low. And unfortunately, in our African countries, sub-Saharan Africa, the numbers are very, very high.
And you're saying that PPH is one of the biggest contributors to maternal mortality in Kenya?
It is actually what we call the big five. They are big five, and it's one of the big five, and it's actually number one. The big five are PPH, that is postpartum hemorrhage. Then we also have preeclampsia, and preeclampsia is basically when blood pressure in a patient goes high while she's pregnant. Meanwhile, when she was not pregnant, the blood pressure was okay.
Yeah.
So that is preeclampsia. That is number two. Number three, we have sepsis as well. Unfortunately, we have post-abortion complications, and then lastly, we have obstructed labor as the big five in this part of the world, and especially in Kenya.
If we look at the numbers, so 355 out of 100,000 births, or according to these other agencies, about upwards of 400.
Correct.
So let's pick a figure for purposes of this conversation. What do you want us to deal with?
Let's take 355. That's the official number.
Okay. So the 355. So 3,555 out of every million births.
Out of every 100,000.
Out of
No.
3,000.
3,000.
Out of
Out of every
3,000 is out of now a million.
a million. Correct.
Right?
Correct. Sorry.
And
yes,
if we are having about 1.6 million births a year,
yes,
that means that we are losing about 4,000 women
correct.
at childbirth
Correct.
every year.
Every year.
And the number one contributor is postpartum hemorrhage,
Which accounts for about 40 to 45% of those figures.
And the reasons that you gave us that postpartum hemorrhage happens are uterus is overstretched, a big baby.
Yes.
What are the reasons?
They can also be because of bleeding, because of tears.
Okay.
The baby has been born, and then in the cervix, because the cervix is basically the entrance into the womb, you find there are tears which are not recognized. And
These things can be detected by medics
They can.
during pregnancy.
During pregnancy, after delivery, because you're talking about delivery now.
If the
Postpartum hemorrhage. Yeah.
if the uterus is overstretched,
Yes.
can this be detected before birth?
Yes, it can.
If the baby is big, can it be detected?
Yes, it can.
So then we can know that we expect to have a situation here and how to handle the situation
What we call risk factors.
at delivery.
Correct. If you have two babies, a woman is carrying two babies
Yeah.
or more, that is also a huge risk factor.
risk factor.
If the patient had bleeding, postpartum hemorrhage in previous pregnancy, that is a risk factor. If she had preeclampsia, that is also can be a risk factor, and so on. So we can actually sort of stratify and sort of have a risk factor. This patient has come. This is the first time she has come to the clinic, and this is her history. So going forward, there is a high likelihood that this patient is a candidate for postpartum hemorrhage. You asked about what age brackets does this also take place. We also see this in younger women. Like now, for example, Kenya has one of the highest adolescent pregnancy rates in the world. And remember, when this young lady gets pregnant, it is basically a baby, a child.
Carrying a child.
And the body is not yet accustomed, is not ready for this. So you find that they have a lot of problem delivering naturally. And if when they deliver, most of the time by cesarean section, they end up having postpartum hemorrhage, sometimes even preeclampsia. The older patients as well. Using older is not a very good term.
If you're older, you are older. Okay, so I am old, so I understand now.
It's older than teenagers.
Older than teenagers.
Yes. No, I think it's referring to people who are perhaps beyond 40,
beyond 35, 35,
yes.
36.
Okay. Yes.
So we also see there is a tendency for them also to have these complications,
Why?
postpartum hemorrhage. Now, it's not very clear, but what we think is that, number one, quite a number of them have gone through quite a bit of issues. They've tried to get pregnant, it has not worked, and when they do get pregnant, there's a high risk of preeclampsia, the pressure increasing. Even when you have sort of stabilized this pressure and they go to deliver, you find they lose quite a bit of blood as well, and quite a number of them also undergo IVF treatment because of age, and IVF, we know, is a risk factor for these women carrying more than one baby, and that also is a risk factor for that. And then,
so you're saying older women who are giving birth for the first time?
For the first time, and even subsequent. Let's say, for example, she has delivered 5 times.
Yep.
And even if the babies were okay in the sense that 3 kilos, 3.5 kilos, and so on, we usually stratify that as a risk factor in itself, because remember the stretching of the uterus and so on. So what you call grand multiparas, they have delivered more than 3, 4, 5 times. They usually have a tendency of having postpartum hemorrhage.
Our Health Friday conversation this morning is on postpartum hemorrhage. Why it's the number one killer of women in Kenya. Well, Scary, statistics are showing us that we are losing over 4,000 women every year at the point of giving birth. And the number one cause, with 40%, at about 40%, number one cause on this is this postpartum hemorrhage. Dr. Kireki Omanwa is the president of the Kenya Obstetrical Gynaecological Society. He's here to educate us about this. Of course, now the next thing we want to tell us is how we can know about the risk factors and how we can reduce these deaths. The risk factors are known, and the risk factors can be detected early during antenatal visits. The risk factors, therefore, can inform the health workers what to do to save these lives. Okay, so where is the gap?
I think the gap is huge. Maybe I can illustrate this by a small story, and this is something which happened to me not too long ago in one of the private hospitals. I had finished a procedure I was doing, and I was going to change and go and do other things. And then one of my colleagues met me in the corridor, and she was shouting. He said, "There's horrible PPH, come to theatre," I think theatre 3 or theatre 4. Right. So obviously that is an emergency. And I ran to that theatre with my colleague, an anesthetist. And when I reached there, I found my colleague struggling. And when I asked, a quick history of the patient, said this was a young lady, 31 years old, who had come at term, that is at 40 weeks, and she had delivered a beautiful baby girl. And soon after that, she had started bleeding with nothing really was the cause. So, and she had struggled with this patient. And I said, okay, can I have a look? And said, there's a way that, a certain way which we are programmed to think when in such situations. Did she have any tears in the vagina? No, there were no tears. Just a small whatever, and she had put 1 stitch and there was nothing there. The cervix was okay, there were no tears, but believe me, she was bleeding like a tap.
Wow.
She would put what is called an abdominal pack, what we normally use for surgery, just to try and stop the blood from flowing. And after 2 minutes, it would be completely, soaked. So, as we are doing this, I asked the anesthetist, have you given medications? Said, yes, I've given 1, 2, 3, 4, and there are medications which you normally give in such a situation. And so I asked my colleague, can I have a look, fresh eyes? So, and I looked, checked the vagina, checked the cervix, everything is okay. The uterus is contracted, but she's pouring. So when I put my hand inside the vagina, I felt that at the back of the uterus, there was a structure there. So my thinking was that possibly there could have been a fibroid, or there was a fibroid, and the placenta had been lying on the fibroid. So when the placenta came out, the vessels which were on the fibroid could not constrict, could not be blocked. So she was basically bleeding from there. So So in such a situation, there are things which you think about and you want them to be done in a certain way. So I asked, do you have what you call a uterine balloon tamponade, which I have here. If you allow me, I can show it to you.
Please do.
Please.
Yes, this is what you call a uterine balloon tamponade. It's a very simple contraption, I would say. This bit here goes into the womb, and in this bag we add fluid. We open here, and we pour fluid, about a liter of it, and then we hang it about a meter and a half above the patient. And what will happen is that
How long is that thing that you're holding?
this is about, maybe, I would say about 2 meters, maybe.
Okay.
I would say, yeah. So the idea is basically this plastic material that is here, when it goes into the womb, and we pour fluid, because now fluid will be going down into this, it will expand, and as it expands, it will block the vessels from bleeding. So I asked, do we have a UBT? No, there's no UBT. So what do we do? In the meantime, the blood pressure of this patient is actually dropping, and you can hear it on the anesthetic machine. I said, okay, get me a catheter. A catheter is basically a small tube which we normally use in the bladder when we are doing surgery, and we take this and insert it inside the bladder.
Okay.
So the idea of using the catheter, the principle is basically the same as this one. The only thing is that with the catheter, we need to put something here which will be similar to this plastic material here. And what we normally use is a simple condom. This is poor medicine for poor people because it is not used anywhere.
So on one end of the catheter, it goes into
this one will go in. We have a condom, and do you mind if I open the condom?
No.
Yes. So we'd open the condom, and we would attach it now to the end of the catheter.
Okay.
And then we would actually take a suture and then tie it around here.
What is a suture?
A suture is basically, let's say, a thread. All right?
Okay.
What we use for surgery. So I would use this, and I would tie the condom on one end such that there is no fluid which is going to be lost. Okay? There will be no leakage. Once I've confirmed that it is tight, then I would use a small instrument and insert this inside the womb. Once I've done that, I would now pour fluid through an opening here. And that fluid can be about 200, 300 milliliters of what we call normal saline. Any fluid can actually do in emergencies. So what will happen is that this condom will swell.
Yep.
And that is, as it swells, it will block the vessels which were bleeding. So I asked in theater at that time, do we have a catheter? Yes, there was a catheter. Meanwhile, remember, this patient is still bleeding. Can I get a condom? And there was no condom.
There's no condom in the hospital.
In theater.
In theater. Okay.
In the hospital, for that matter.
Okay.
So after a few minutes, meanwhile we are struggling to control this bleeding.
It's minute by minute.
Yes.
Right?
Yes. So anyway, one of the nurses strolled out and came back with a condom and said, "Excuse me, I wanted to say something. I got a condom, but I want to say that it was not in my handbag." We say we don't care where it was.
This is not the time for that conversation.
We don't care. Just give it to us.
Hey.
Just give it to us. No. So when we fashioned this is basically a uterine balloon tamponade, just like the one that I showed you, and we inserted it inside the womb, and we pushed in fluid, about 250 milliliters. The bleeding stopped.
It blocked the vessels.
It blocked the bleeding, and it stopped.
Okay.
We put in another abdominal pack just to make sure that everything is okay. And after it stopped, this patient was transferred to ICU. It was on a Friday. When she came to hospital, what we call her HB, that is the amount of blood that she had, was 11 grams per deciliter. The normal is between 11 to 13 to 15, depending on what lab you're using. When she went to ICU, we checked, because we do that before we give blood. Her HB was 3.1.
Wow.
Yes.
She had lost that amount of blood.
She had lost about 2 liters of blood. So in essence, she was on her way out. A healthy young lady delivered a healthy baby, came into hospital walking. Potentially she could have gone out in a casket, in a box. She went to ICU over the weekend. She was given blood. She was given medications. On Monday, she was as bright as day. She went home with her baby. What saved that woman?
Hold on, Dr. Ari.
Yes.
At what point was this thing removed? The condom.
24 hours afterwards.
So you just pull
We
it
just
out?
insert it, and once we assure now the uterus is well contracted, there is no more bleeding. We just remove the fluid, and once the fluid has come out, the condom will collapse, and then we just remove it out.
How do you know that the uterus
has contracted.
As contracted, by checking, by just massaging the abdomen, we can actually feel that it is hard. And we know that it is well contracted. Because when it's not well contracted, it's soft and it's boggy. And then apart from that, we know the size of the uterus as well. Because we know after delivery, it should be around, let's say, 18, 20 weeks. But if it's 28 weeks, 25 weeks, and it's after delivery, something is not okay. The uterus is not contracting properly.
There was a mention of fibroid, or the possibility of fibroids existing.
Yes.
Did you confirm that indeed there were fibroids? And if so, what was done?
It was my theory, because we would have had to do a scan. But at that moment, what you need to do
Was to stop that
to
bleeding.
stop the bleeding.
Yeah.
That is the most important thing.
So what would one do in such cases? She's gone home.
Yes.
Would she then be asked to come back so that she can have other tests to determine what it is the problem was? Because if she's young and she wants to have other children, what then happens if you have a repeat performance?
Now, immediately what happened, maybe I can go back a little bit before I answer your question about what are the issues.
Yeah.
And I use this as a prime example. And it is something which happens to, or can happen to, any of my colleagues who is practicing obstetrics, whether it is in the private sector or in the public sector or in the faith-based or whatever it is. This is something that can happen to anyone. That is why we need people who are experienced, people who know what to do, and people who will not lose their heads when they see so much happening at the same time. Because remember, here you are listening to what the anesthetic machine is telling you, and here you are trying to find out what the problem is and solving it at the same time. And time is of the essence. Several things actually helps us to save this woman. Number one, we were 3 consultants. There were 2 obstetricians and an anesthetist, very experienced, and we knew what to do and where to do it. Number 2, there were medications, quality medications. A study was done not very long ago, actually by a group of my colleagues from the university, Department of Obstetrics and Gynaecology, and this was a study done in Kenya, I think it was Tanzania, and Nigeria and another country, where they looked at over 240,000 pregnant women who delivered. And they also looked at the quality of the medications that these women were getting. And unfortunately, it's very sad to say that in Kenya, some of the medications they were getting, and it was a random sampling, was actually poor quality medication. What do I mean by that? It means that medication X, which says it should have a certain chemical of certain strength, 10 units, 10 milligrams or whatever it is, it was found that it was not actually true.
It had more or less.
It had less. So you find you are giving this medication and you are expecting the uterus to contract and it doesn't contract. And you give more and it doesn't contract. So you are wondering what is happening. So quality medications. We had quality medications. Number 3, we had blood. Blood is a problem in this country. We collect as a country 276,000 units of blood, which is about 60% of what the country needs. We need about 500,000 units of blood per year. And guess what? 70% of these 276,000 units are used by who? By women who are expectant, who bleed during delivery or after delivery. This hospital had an ICU which was well equipped, it was functional, and it had people who were trained to actually monitor these patients. Now, these are what you call pillars. And then, of course, there are consumables, where, of course, we got the condom and so on, and so on. So you have human resource, which are the doctors and the midwives as well who are working with us. We have medications, quality medications. We have blood. We have consumables. We have an ICU, which is functional. Unfortunately, in most of our hospitals, government hospitals, you may not find all these pillars, all of them at the same time. In one, you may find, yes, the consultants are there, but there is no blood. You may find the consultants are there is blood, there are no medications, there are stockouts. The consultants are there is medication, there is blood, there is no ICU. Or if there is an ICU, it's a caricature of an ICU. You have a building, but nothing more. Or you have a building which has machines, but you don't have people who can actually monitor these patients. So these 5 pillars, if any one of them is lacking, then unfortunately we are going to lose these patients. And most government hospitals, you will find that 1 or 2, or sometimes all of them are missing. And that is the tragedy that we are looking at. In the meantime, in the morning, I heard City saying there was how much? 17 billion, which was used for
17 billion. Governors and MCAs.
Just for people in the county,
they traveled here and there. Morocco, Singapore, Tanzania, Uganda.
Yeah, which is sad, unfortunately.
This is the thing. It's about the investment in healthcare.
Correct.
On all these aspects that you've said. We invest in training doctors, clinicians, nurses, and everyone.
Yes.
We invest in having the facilities and equipping the facilities.
Correct.
And making sure that everything is working.
I did a small sort of a study, call it a study. I asked my colleagues from the office, that is the COGS office, to call all referral hospitals, county and sub-county hospitals, 98 of them, just to find out how many of them have this, what you call the uterine balloon tamponade. First of all, about 42% of them declined to answer our question. It was a simple question. We are calling from COGS. This is the Kenyan Obstetrical and Gynaecological Society. We just want to find out, do you have something called a uterine balloon tamponade? They said, first of all, who are you? This is a government hospital. We don't give information. And so on.
Ask the ministry.
Now, of the ones which did reply, I think there were about maybe 4 or 5 of them which actually had this in store. 4. Others had never heard about a UBT. So, and this is something which is
what percentage had never heard?
If you remove the 40% which said they cannot give information because it's government, so we are left with 60.
Yes.
Of the 60, I think about 4 or 5 of them had them stocked. I would say maybe about 20 or 25 of them had never heard about UBT.
Never heard
about UBT.
Kenneth Omondi is asking, ask Daktari, is the reproductive health division at the health ministry still functional?
It is functioning.
Where functioning means what exactly?
Where functioning, I'm not holding forth for the reproductive health division.
Well, you said it is functioning. I want to understand what you mean.
There's an office,
yes,
and there's a director.
But we do meet as COGS. They call us for meetings, and we are in technical working groups, and we've been working quite handily with them. I must say that they have done something which is very, very good. They have spearheaded the availability of one drug, which is called carbetocin, and this is available because I talked with one of the guys and they told me that they had imported, I think, 260,000 vials, which are available in KEMSA, and this drug is one of those basic requirements, basic treatments that we use in such cases of postpartum. So in that respect, that's why I'm saying it is functioning. They have done that, which I think is commendable. However, I think we can do a lot more.
There is data that indicates to you clearly regions where perhaps this condition we are speaking of is higher than others.
Correct.
Now, if we were to do a different survey and ask this very critical medication,
yes,
does it reach the places where it is most used? Because I'm asking the question from the point of view of the procurement processes. We understand, we are told about them, we tend to understand them.
Correct.
We're even told where the drugs are domiciled. But when you get to where it is needed, there always seems to be a problem. We even saw that with the COVID.
Yes.
When we were being told that, yes, the vaccines have arrived, okay? They were even escorted. They're in this central place. But before they got the act right, places where they were needed, one did not find them. When you ask, you're told that they're there. You go, actually, we are there, and they're not there. So we don't understand. That's why I asked that previous question. Do these things get to where they're most needed?
I would say that sometimes, yes, they do. And sometimes they are stockouts. And then the procuring process also has an effect. So, yes, sometimes they're there. And unfortunately, most times they're not there. That is just one of the problems. We have counties whereby you have, let's say, 2 consultants in a county. 1, 2.
By consultants, we mean OBGYNs?
OBGYNs, 2 consultants in a county.
For the entire county?
For the entire county.
Right.
Yeah. So you remember I talked about human resource as one of the pillars. So if you have 2 consultants in a county, there is no way you are going to be able to actually save these mothers.
Can this knowledge, at least a bit of the knowledge, be transferred to the other doctors? The clinicians who are in hospital?
Yes, it can.
And I want to ask that question as I head back into risk factors are known. Risk factors can be detected early during the antenatal visits into hospital, right? If a woman who is expecting a baby is seen to have these risk factors, is there something that can be done to reduce the effect, to reduce the chances of them having PPH?
Yes, something can be done. And what are these things that can be done? Number one, I think the knowledge of that you are pregnant, because most people say being pregnant is not a disease. This knowledge should actually go out there. Say, when you're pregnant, please visit your doctor, your healthcare facility, and so on.
At least how many times during the pregnancy?
The WHO recommends 8 contacts. Some of them come without any contact at all.
Wow.
Some of them come without having even had a blood test done. And anemia, we know, is one of the risk factors as well of PPH. Some of them don't even know their blood group. So there are quite a number of things which can be done. But if they were to visit their healthcare facilities where we have midwives, we have doctors, and so on. These are things which can be picked up very, very easily. That is number one. So we identify these patients who are at high risk. Number 2, we need to retain them. What does that mean? We have identified that Madam Joyce has a problem, or Madam Joyce has a high risk of PPH. So how do we follow her through? What are her contacts? How can she be better followed? So the retention bit. And then the other one is, how do we respond to what we have? You say, okay, we've identified you've had 4 or 5 babies, and they have been big. So please make sure that you come, at given times for follow-up. And then when it gets to the time when she's supposed to deliver, where is she supposed to deliver? These women are supposed to deliver in places whereby they have these pillars that I mentioned about.
So about a level 4, level 5.
Level 4, level 5. Just by doing that, we will have reduced a huge amount of these women who die because of falling through the cracks, and then they go to deliver. Sometimes they have home deliveries and so on. The uterus does not contract, the placenta does not come out, and so on. Birth attendants may not actually have an idea about the physiology and pathology of such women, so they think it's just a normal delivery, and then things go south. And when they go south, they really, really go south.
Do the medics know this?
Yes, they do. Actually, whenever our students rotate in our department, in obstetrics and gynecology, this is one of the things that we emphasize about, the big 5. And there is something that we are planning to do. We are planning to put sort of algorithms of what to do in these big five, such that when these medical students, interns basically, go out there, they have something like a booklet where if they see a patient, come into contact with a patient with preeclampsia, do 1, 2, 3, 4,
right.
Stabilize the patient, refer. If there is postpartum hemorrhage, do 1, 2, 3, 4, stabilize. And if you're in a facility which cannot handle such a patient, then refer. But then there are also other issues. There are issues of infrastructure. Roads may not be okay. You can do all this, but you find that the infrastructure is not okay.
No
ambulances
ambulance.
are not there,
Yeah.
etc.
We have to properly invest in our healthcare, and there are no questions about it. Dr. thank you very much for joining us.
Thank you very much. I would like to invite you for a run that we are organizing on the 6th of October. And this is basically to raise awareness about PPH. It's a short run from Ulinzi Complex all the way to Nairobi West and back.
How many kilometers are those?
That's about 8-10 kilometers only.
Okay. Are we
Yes.
allowed to walk?
We are allowed to walk. We are allowed to ride a bike. We are allowed to
Just cover the distance.
6th
of October.
6th of October, and you can register at endpph.com.
endpph.com. And PPH is Post-Partum Hemorrhage, which is what Dr. Kireki Omanwa, who is the president of the Kenya Obstetrical and Gynaecological Society, has been teaching us about this morning, understanding postpartum hemorrhage and why it's the number one killer of women in Kenya. Keep it here for more conversations.
This is The Situation Room, the only way to start your day.